So I'm really pleased that you're all joining us today for this webinar by the British Psychological Society on meeting the psychological needs of people recovering from severe coronavirus disease. And I'm really pleased that we've got people from many different professional backgrounds to come together for this talk, particularly because I think to achieve what it sets out in the title, we really will need to work together across different disciplines. I'm also particularly pleased that we have people from all around the world. So at the last count, we had people from 33 different countries. If you're in the people that are here from Peru, it's Buenos Dias to you. It's 10 a.m. in Peru. It's 9 p.m. in India and Bangladesh, midnight in Japan, so konbanwa to people in Japan, and it's 3 a.m. in the morning to a number of people joining us from New Zealand. So there's a special prize for being keen if you're coming and joining us from New Zealand. So I think there's lots of obviously challenges with this pandemic and real tragedy that's come out of it, but one real positive thing that's come out of it for me is the fact that a global pandemic has brought us together across the world in a number of ways. And I think that's one real positive thing that comes out of it. So I really want to welcome everyone who's joining us from outside the UK today. We'll just start by introducing ourselves. I'm David Murphy. I'm the president of the British Psychological Society 2019-20 president. It's a slight irony that today's the first day that I've spent the day out of bed, having spent the last week in bed with suspected coronavirus, and I'm trying to sort of get myself up to give this talk on, with Dorothy's help, on recovery from coronavirus. My background is as a clinical psychologist, and I've worked for our National Health Service for about just over 30 years, and the vast majority of that time has been in acute hospital settings. My first job was in working in spinal injuries, and I've worked over the years in cardiac rehab, diabetes, chronic pain, trauma, and clinical neuropsychology. I was the head of a psychology service in London for many years at Imperial College before going into clinical psychology training and becoming the director of the Oxford University Clinical Psychology Training Institute. Now, alongside my BPS role, I'm leading a research study into clinical leadership. And I'll let my co-presenter Dorothy introduce herself.
Yes, good afternoon, everyone. So I'm Dorothy Wade. I'm a health psychologist, and I started off by doing research into psychological aspects of being a critical care patient. And that led me to a role as principal health psychologist at University College London Hospitals NHS Trust. And that's where I am today. We've been very much at the, I think, epicenter of the UK coronavirus outbreak in central London. So we've had a huge number of coronavirus patients in the hospital. And my role has been to try to lead support for the staff, families, and patients involved in the pandemic.
Thanks, Dorothy. I should have mentioned earlier, but I'll mention it now. I don't think we've got the chat function enabled, but we have got question and answers. Hopefully you should be able to ask questions and also upvote questions that you want us to answer, because by definition, with nearly 500 people here already, we're not going to be able to answer everyone's questions. So do use that upvote facility. Hopefully it's visible to you. But what we have done, instead of doing chat, which we've, it's fine for while you're actually on the webinar, but it disappears immediately afterwards. We've got the hashtag C19 recovery, which I don't think is used. So I think if you tweet with that, you should be able to just tweet specifically using that, and then that'll enable us to keep the conversation going after we've finished speaking today. The plan for today is that Dorothy and I are going to talk through the BPS guidance for about the first 40 minutes, and then the last 20 minutes we'll have some discussion, and we'll be joined by a couple of discussants who I'll introduce as we go along. Okay, so I'll start by yes. I won't spend long talking about COVID-19 because I suspect if you turn on the TV, it's pretty much everything that you see at the moment. So I'm not going to waste any of your valuable time talking about it really. But I mean, just to note really that it spread obviously incredibly quickly across the world from the first reported cases in December 2019 in Wuhan in Hubei province to really across the world now. And earlier today there was 3,750,000 confirmed cases, and estimates vary, but probably about 5 times that many actual cases, and 250,000 confirmed deaths around the world. So this really is a global problem, a global issue that we're facing. And we're talking particularly today about the longer term effects, the recovery from severe COVID, and the particularly psychological needs of people recovering from COVID. And to some extent, we might think that we don't know very much about that. And it's certainly true that we don't know a huge amount about it, given that the first cases were only described a matter of sort of 4 months ago. Although there is some early papers from China describing a number of different aspects of the experience of COVID, and actually one rehab study that's already been published. But it's true to say there's not a huge amount on it. But I think what I'd really like to emphasize is that we do know a lot about other things that are very relevant. I mean, one thing that we do know about is SARS and MERS, which are similar related coronaviruses. And certainly with SARS, the outbreaks in 2001 were 2003 were quite well studied, particularly in Hong Kong and in Canada. And one of the studies in Hong Kong followed people up 4 years later and found that, this is Lamb 2013, found that 42% of people met criteria for at least one mental health diagnosis 4 years later, and 27% of people who'd survived SARS met criteria for chronic fatigue syndrome. So that certainly indicates significant long-term effects. We also know a lot about critical illness, and Dorothy is somebody who knows a lot about critical illness. Particularly relevant here is acute respiratory distress syndrome, ARDS, and the ALTOS study in the States found that survivors of ARDS, 70% of survivors of ARDS were in a cohort study had clinically significant fatigue at 6 months, and 66% at 12 months. And a quarter of those people had got worse from 6 to 12 months. So certainly indicating that fatigue is a very significant aspect of recovery from ARDS. And other studies have found significant frequency of cognitive impairment. So Mickelson 2008 found a quarter of ARDS survivors had memory impairment and 30% had impairment of executive functioning. Particularly relevant given the high prevalence of fatigue in people recovering from critical illness is what we know about management of chronic fatigue syndrome. And there is quite a literature on management of chronic fatigue syndrome, particularly cognitive behavioural approaches and the relevance of health beliefs. And Rona Moss-Morris has done a lot of work in this area, who was one of the members of our group. And certainly she's found that anxiety and beliefs play a significant role in the likelihood of developing chronic fatigue problems. We'll talk a bit more about that later. Of course, we know a lot about cardiac and pulmonary rehab and self-management. Things like the heart manual is very well described and used in cardiac rehab. In COPD, the breathlessness manual is used here in the UK, that was developed by Simon DuPont, who at Hillingdon Hospital, who is another member of our panel. We also know about neuropsychological rehab. We can draw on other areas. And finally, we know a lot about treatment of health anxiety and post-traumatic stress. We know effective approaches for these. So I think what we do know is that there are significant consequences of very similar conditions to COVID. And we do know that there's lots of approaches that are effective in tackling and managing some of those difficulties. So with that, I'll hand over to Dorothy to talk a bit more about the clinical features of COVID. Oops, no, I won't. I'll introduce the Guideline Development Group. I won't go through them all individually, but this is what we look like in action. And the guideline, I mean, we were able to draw on people who had expertise in all of those areas, which was really fantastic. I'll just highlight two of the members. In particular, we were able to draw on multidisciplinary input. Our occupational therapist colleague and our physiotherapist colleague were provided some really helpful input. And also we had some really invaluable input from the patient relative members of the ICUsteps organisation, and we're fortunate to have the chief executive of that as one of our discussants. So now the guidelines itself is available on the BPS website at bps.org.uk/responding-coronavirus if you want the full document. It's only 5 pages, so it's not a huge document. So now I'll pass over to Dorothy to talk through some of the clinical features.
Thank you, David. As David said, you probably all know more than you ever wanted to know about coronavirus disease by now. But just to touch on a couple of key points, which probably point to some of the psychological effects. This is based on World Health Organization guidance. And so we do know, as it's often said, that 80% of people will have only mild or uncomplicated illness, which I hope has been the case with David. Will develop severe disease that requiring them to go to hospital.
Breaking up a little bit, Dorothy.
Okay.
See how it goes. Maybe.
Should I stop my video? Maybe.
Maybe keep going for now, but you may need to turn your video off.
Okay. So 14% will be admitted to hospital and require oxygen support.
Oh dear. Try turning your video off, I think, Dorothy.
Okay. And in those severe cases that require admission to intensive care, COVID-19 can be complicated by acute respiratory disease syndrome, sepsis and septic shock, multi-organ failure, in particular acute kidney injury, which we've certainly seen a lot of, and effects on the heart. And we also know that there's an increased likelihood of venous thromboembolic events in COVID-19 in those particularly severe patients. And this could have implications for cognitive function as they go forward. Turning now to psychological aspects of recovery from COVID-19. We know from our critical care population that about 1/3 of patients do suffer from quite severe anxiety and low mood following discharge from the hospital. But on the other hand, that means the majority actually experience positive emotions. They are extremely relieved to have survived. They feel gratitude to the healthcare staff that helped them. They feel almost like they've got a new lease of life, and they experience personal growth. So it's not all bad news. However, some patients, about 20%, find that they're experiencing nightmares or flashbacks to their time in the critical care unit. And perhaps as a result of that, there's a very high prevalence of insomnia, both in the hospital and after leaving hospital. It can take quite a long time to get decent sleep patterns re-established. We also know there are about 1/3 of patients notice cognitive effects on their memory, their ability to pay attention, their information processing speed or mental processing speed, and executive function. Those are what we know from the critical care experience. And what we've learned from COVID-19 is that people who've suffered a sort of infectious virus are also very likely to feel very frightened of the illness returning or of catching another infection. And they become aware of all bodily or physical symptoms and can become very worried every time they notice a bodily symptom. And equally, we find in pandemics that people who've already had the virus fear that they're stigmatized, that people believe that they're still infectious. and they really worry about contaminating others around them. So those are the long-term effects, and we know that there are risk factors from the hospital stay that make you more likely to have these psychological difficulties later. So looking first at clinical risk factors, these include having been on a mechanical ventilator or a breathing machine, and it appears that the longer you're on the breathing machine, the more likely you are to have psychological effects. When you're on the breathing machine, you are intubated, as we say, which means that you'll have a tube in your mouth which is delivering oxygen down through the trachea to the lungs. And this means that patients are not able to speak or communicate while they're on the ventilator. And many patients don't understand why that is. So they're really frightened that they've just lost their ability to talk, maybe in a permanent way. And also, due to being on a ventilator, patients tend to be sedated so that they can stay calm and comfortable and not moving around too much on the machine for their safety. However, we do know that the longer you're sedated and the more deeply you're sedated, and also given certain choices of sedative agent, you may be more at risk of future psychological difficulties. And we also know that the sheer number of different invasive procedures that you receive for organ support and critical care, that does also increase your risk of psychological problems in the months after leaving critical care. So as well as the clinical risk factors, there are psychological factors about how you felt when you were in the hospital. So you can imagine if you're in critical care, it's very common to feel extremely stressed, very frightened, and a lot of people are quite withdrawn with a low mood. And that seems to put you at a greater risk of depression further on. Another common experience in critical care is that when patients come out of this period of sedation and ventilation, they often feel very confused and delirious. And part of that delirium can mean that they have bizarre or very frightening hallucinations and delusions, meaning strange beliefs about what's happening to them in the intensive care unit, and often really struggle to know what's real experience and what's not real experience. As they wake up, they begin to realize that they feel very helpless and they feel a loss of control. They suddenly realize that their care is in the hands of other people and of the using sort of complicated machinery. People do feel quite helpless about that. And then finally, a further psychological risk factor is having fewer factual or real memories of being in critical care on the hospital, and more intrusive or delusional memories. By delusional memories, I mean a lot of people have flashbacks or intrusive memories of the hallucinations and delusions that they experienced in critical care, rather than real events that happened in critical care.
That's really interesting, Dorothy. I mean, sorry to sort of butt in, but that factual memories is a finding in PTSD generally, isn't it? I'm not familiar with the literature in intensive care in particular, but you could see that sort of relationship between delirium and subsequently developing PTSD. Is that what you're saying?
Yes, it's very similar to that. Yeah, the sort of fragmented, emotional, sensory type memories that might experience in PTSD. Yeah, and we do. The literature is not conclusive about this, but it does seem that people who suffer the hallucinations and delusions are more at risk of developing post-traumatic stress symptoms following the discharge from hospital.
Right, and then we're going on to the next slide about, actually I'll do that rather than talk about it. But I was just going to ask you another question. In the COVID pandemic, I think anecdotally I've heard a number of people saying that delirium seems to be a more common feature of people with COVID than other similar conditions. So in that sense, we might expect that to be, the prevalence of these sort of sequelae related to memory and post-traumatic stress to be higher in people with COVID?
Yeah, I mean, it certainly appears that patients are extremely delirious. I mean, the good news at the moment is a lot of our patients in the hospital are now at the stage where they're waking up. They've come off the breathing machine, but as they wake up, they do seem to be extremely agitated and distressed for a period. And we do think that, yeah, as well as the normal critical care factors, there are some extra issues about COVID that could exacerbate the problems. So one of these is the fact that there are real physical barriers to seeing the people looking after you and communicating with them due to personal protective equipment. You've got the photograph of the nurse there, but in fact, I think in reality, it's a lot more frightening looking than that. The mask that you can see, we have hats covering all our hair. We have a visor covering our whole face. So actually people can only see our eyes. We have a gown that goes more or less from head to toe. We have 3 or 4 pairs of gloves, and we have 2 aprons at times. So I think that it's quite a common delusion of patients waking up in critical care, is that they've been kidnapped by aliens and taken to another planet. And I think that we probably look like aliens on another planet. I mean, of course, we are the only ones they see because, unfortunately, family members can't come to the hospital at the moment. So family members are usually a huge support to the critical care patients, but they're prohibited from visiting. So the patients feel very isolated and alone. And as I said, at the best of times, there are a lot of stressful aspects of intensive care. There's a lot of noise, there's a lot of busyness, a lot of quite disturbing noise like alarms going off constantly, monitors beeping, and so on. Often the lighting's not very good, so it's quite rare to see daylight and have access to a window in an intensive care unit. And this has quite profound effects on people's circadian rhythms, so they become very upside down in the night-day cycle and can't sleep. And this is exacerbated at the moment by ward conditions during the crisis. So, for example, our intensive care unit has had to double, or actually probably treble in size. So we've had to move out of our sort of purpose-built intensive care and take over theatres, recovery areas. Many of those areas are not designed for this at all. So they don't have windows, there's no natural daylight, and conditions can be very cramped and hot, which has impact on both the staff and the patients. We've also found in COVID in other countries and now here that patients do seem to have to be ventilated for an unusually prolonged period of time. They often have to be kept prone to turned on their fronts, and they often have to have paralyzing agents to keep them still and keep them safe. And as we mentioned earlier, I think as a result of that, people are sedated for longer, they've been sedated more deeply, and we've used more benzodiazepines for sedation than we normally do, because those are not really the drugs of choice for sedation. For the patients who've come out of that phase and they're more awake, there's then the chance that you're going to see a lot of other people in a very distressing circumstance, patients on ventilators, patients unconscious. Unfortunately, some patients have seen several other patients die. And in the very cramped conditions that we have, that's almost unavoidable. And again, patients who are more awake, they may have come into the hospital already having heard about, oh, there's a lack of staffing, there's a lack of equipment, and they may have concerns about their safety due to those factors. So I think it's there's quite a lot of risk factors for these patients that we're trying to mitigate against. Okay, so I spoke about mitigating against this. So what can we as psychologists and other members of multidisciplinary recovery teams, what can we do to try to support people and really reduce these psychological risk factors and lessen the difficulties? So looking at this as a kind of pyramid, on the bottom layer, we have the type of care that everyone should get, regardless of needs. So All patients should receive really good psychological care while they're in the hospital, and should be provided by, you know, really clear, patient-friendly information, both in the hospital after discharge and then follow-up services later. Going a little bit further up the pyramid, there should be structured rehabilitation packages and self-management guidance and advice, probably from patients who've been identified as having further needs, psychological and physical. And then finally, for the minority who are going to, you know, perhaps develop post-traumatic stress disorder, or become very depressed, or have some, or find that they have cognitive impairment, then there should be access to specialist services. So we're going to talk a little bit more about each of these layers of the pyramid. Yeah, so before I mentioned that before leaving the hospital, obviously given the type of experience that we've described patients undergo, it's really important that all patients with severe COVID-19 should receive psychological care from all members of the hospital staff. Actually, it's not just something for psychology, as well as receiving information about their condition and their treatment in a patient-friendly way that they can understand, not being bombarded with medical jargon that they're not going to understand. So the first step there is that all healthcare staff working in COVID areas, we need to remember that many of those normally don't work in critical care, so they may not have any experience of some of the delirium and so on that we talked about. We're trying to ensure that those staff receive training in what we call psychological first aid, which is designed to make patients feel safe, calm, connected to others, confident in their recovery, and hopeful, realistically hopeful about what can be achieved. And this first aid is to relieve fear and to help them understand and realize that emotional reactions such as anxiety, panic, and low mood are very normal given the experiences they're going through, but also to understand much more other distressing experiences such as delirium with its hallucinations and delusions, and also more about their clinical condition. And again, for staff who are not used to working in this area, knowing how to manage critical care patients who are very agitated, very distressed and hallucinating, and can become, you know, even aggressive and combative is very important. And you can find some guidance for staff available at the moment on the Intensive Care Society website. We've got some easy to read guides in the principles of psychological first aid. So psychologists should be involved in giving that kind of training and support to other clinical staff. But in more complex cases, for example, where the person has pre-existing mental health issues, or where they are extremely distressed and very delirious, those patients can be referred to clinical psychologists or health psychologists in the hospital. And it's also worthwhile thinking about, once patients wake up from the very acute phase, that we want resources to keep them distracted and entertained, so they're not just spending the whole day worrying and ruminating about being ill and their recovery. So it's a good idea to think about having iPads, radios, relaxation materials. Families have been emailing patient, and all these help these are all part of the good psychological care that we aim for in the hospital. Next slide. Yeah, and hopefully with good psychological care, and the patients are now ready for discharge. At this point, it's important that we have quite a few nice guidelines in this area, and they spell out that patients must receive both verbal and written information from a multidisciplinary team. And this should be about the hospital experience up to this point, but it should also include an individualized rehabilitation and recovery plan, specifically tailored for that patient. And we normally would give them that in a special rehab folder. They also need information about if they have any remaining symptoms, that what's causing those symptoms, but also informing them that those symptoms, you know, should definitely improve with time. On the other hand, to tell them what they need to do if those symptoms don't improve. And they should also receive information about common difficulties that might be expected in their physical, psychological and functional recovery that can arise following a time in hospital, and what to do about those. Many critical care units and hospitals will give their patients a special recovery booklet. And in particular, there's a really good one by a patient and charity called ICUsteps. And you know, all hospitals can go to their website and download or purchase these booklets, which are really, really helpful to patients.
And just to plug that a little bit more, I think what's really impressive about that is just the number of different languages it's available in as well. I mean, Peter will probably say later, but it's available in many, many different languages.
Yeah, that's an excellent resource.
Okay.
But it shouldn't just be a one-way street. Sorry.
No, go ahead.
It shouldn't just be a one-way street of information giving. It should be a dialogue with patients before they leave the hospital, so they can leave time to encourage them to ask any questions about symptoms that they're still experiencing, or maybe parts of their hospital experience that they're still very worried about, or that they can't remember properly. Just give them the chance to talk about that, and also to ask any questions they may have about their rehabilitation and recovery plan. Who are the health professionals that are likely to come into contact with them to help with this, and who to contact for help if they have any difficulties later. So after leaving the hospital, patients shouldn't just be left alone to follow the recovery plan, but all patients who've had severe COVID-19 should be proactively followed up. Between 1 or 2 months after discharge. In some cases, this will be by a hospital-based care follow-up clinic. And as we speak, I think about a third of hospitals have these specialist critical care follow-up clinics. But it may also equally be by their GP, a general practitioner, and particularly in areas where they don't have a critical care follow-up clinic. And these clinics and these appointments will be all about reviewing psychological, functional and physical needs. And for psychological, both emotional and cognitive issues. And we normally, from the critical care follow-up clinics, we always invite the relatives to take part in these follow-up sessions, because we find that's really helpful, both for the patients and for the relatives who've also had, you know, quite a difficult time while they've had a loved one in intensive care unit. So, you know, a lot of the focus of the follow-up appointment is giving patients and relatives the chance to ask questions about any aspects of their experience in hospital, just to, you know, sometimes they just want to review what they went through and ask you questions about it. They'll often talk about unusual memories, which may be related to hallucinations that they had in intensive care, which are still bothering them, or they may be still having nightmares about some of these hallucinations. But they can also be quite worried about long periods of time that they just don't remember, and that's of course because they were sedated in the intensive care unit, and those sedative agents do tend to act as to create a sort of amnesia for much of what happened. And it's a really good idea that the healthcare professionals running these clinics have a good understanding of what their experience of severe COVID-19 is likely to have been. And I'm going to hand over to David now to talk a bit more about the
That's great, thanks.
that early follow-up appointment.
That's great, thanks, Dorothy. And I think, oh, your videos come back. And I think one of the points that I think we wanted to make was that this will vary around the country, as you say, Dorothy, and around in different countries who's doing this. But the key thing is that somebody should do it, and it should be proactive, and it shouldn't just be waiting for someone to have a problem. It should be this review, and a holistic type of review that takes place. And we certainly felt that the GPs would be well placed to do this, particularly because the people who have severe COVID are by definition likely to have had pre-existing long-term conditions, so they may well be well known to their GP anyway. So but it's the key thing is that somebody should do it, and it should be coordinated. Just in terms of that relatives thing, and I'm going to speed up because we're sort of running slightly late, so I want to make sure we get to questions. But I think the point about relatives is really, really important, because looking at some of the literature, again, going back to some of the literature on ARDS survivors, there was a study published last year by Robert Lee at the University of Washington that followed the relatives of people who'd survived ARDS, and at 6 months they found that 31% of those relatives showed PTSD symptoms, and that's significant PTSD symptoms, and that's higher than many patient samples. So the distress and difficulties in the relatives, and this is true for other conditions as well. We know this in terms of people that survive myocardial infarction, that the relatives' distress can be just as prevalent as the patients themselves. And also there's an interaction between the relatives' distress and the patient's recovery. So it's important to recognise and also to address that distress. I'll come on to relatives, the role of relatives in rehab in a minute, but the content of this follow-up assessment, we highlighted in the guidance a number of key areas. And I think the most important thing is to touch on all of these areas and to inquire into these areas. We've suggested some brief standardized measures that can be helpful if appropriate, but the key thing is to ask questions in relation to all of these areas. They're in no particular order, but daily routines, particularly Rona and the literature on chronic fatigue syndrome identifies the sort of establishing a daily routine and sleep-wake cycle soon after discharge is a strong predictor of good recovery. So inquiring into people's sleep-wake cycles and the amount of daytime sleeping is a key area. Evidence of starting to return to normal activities. We've suggested that this follow-up appointment should happen 1 to 2 months after discharge. So it may well be that people are not returning to normal activities at that point, or even some of their normal activities they may never be able to return to in some cases. But the evidence of being on a trajectory. The impact on family and social relationships. So, are people being able to re-establish social relationships? The impact, the changes within the family. It's important to because again, they're predictors of recovery. Anxiety, low mood. People will be familiar with assessing those, and I think those two measures we've mentioned there are very standard measures that are used widely in general practice in the UK. Post-traumatic stress symptoms. I think people are perhaps a little bit less used to assessing. The measure we've put there is the traumatic screening questionnaire, which is a 10-item screening questionnaire that was used in the aftermath of the London bombings to screen for PTSD, and certainly showed good sensitivity early after a traumatic event. And it's just basically based on symptoms of post-traumatic stress. But again, the key thing is inquiring proactively rather than waiting for patients to tell you about these things. And the final area is cognitive difficulties. And I think, given what we've said about the frequency of cognitive difficulties, it's really important to be on the lookout for those, because again, they're a strong predictor of recovery and resuming to normal activity, and also stress and difficulties in the family. So it's important to identify those, and that can be by inquiring with the patient themselves, but also relatives, and also in this case, often because people may not be resuming the activities that put particular demands on them, using brief screening measures can be very helpful. The Montreal cognitive assessment we've mentioned there, which is quite a broad one. Some of the brief cognitive assessments focus very heavily on memory because they're designed to detect Alzheimer's disease, but a broad brief measure can be helpful. And these measures, a lot of this we may have to be doing remotely at the moment, but these measures, it is possible to deliver them remotely if you follow guidance about doing that. So I think that's worth just flagging up. In the guidance, we make a particular point about trying to identify personal meaning of physical symptoms. So rather than just listing physical symptoms, just making sure that we try and look at the idiosyncratic meaning, and particularly with a new condition like COVID, there may well be lots of scope for idiosyncratic beliefs about what might be happening, what the sort of consequences of symptoms might be. And so these are the sort of examples that you would ask in a patient consultation normally. What do you worry might be the underlying cause of the chest pain or the breathlessness? What do you worry might happen next? What, to trying to identify that sort of catastrophic fear about what might happen if the breathlessness gets out of control. And that is very informative in terms of understanding what the patient's fears are. And also behavioural. So what do you do or what do you stop doing when you experience fatigue or breathlessness, to identify avoidance or safety behaviours that people use can be really helpful and difficult to pick up unless you actually ask about them. And also I think looking at how other people in the family react. So, it may well be that the patient themselves feels quite, non-concerned about breathlessness, but other people in the family might start getting very anxious to see the patient breathless. So understanding that will really help to understand what's going on. Okay, so the structured rehabilitation and self-management that we're talking about, Dorothy mentioned earlier, really should be offered. This is the sort of middle part of the pyramid, should be offered to anyone with significant ongoing psychological, cognitive or functional difficulties. And it should be a coherent package that's a multidisciplinary package. And, an integrated approach is just so much more effective and efficient, really. You'll end up, the overall amount of input going in will be less if it's an integrated package. It may well be that these packages may be provided remotely, but as we're all learning, that actually a lot of things can be done remotely that you didn't think were possible before, including contact with other patients, which is a significant factor, and involvement of relatives. But again, it should be done in an integrated way, with input to the package from the different specialties and feedback from the package and how it's going to the different specialties, and some opportunity for different OTs, physios, practitioner psychologists and so on to communicate with each other. This image, I think, is really a key one. I came across it and I thought it was the patient sitting with a member of his family, but actually looking at it more carefully, it looks like a physical therapist. But actually, I think with these remote delivery, we have to think about, it takes the focus off us in a way. And I think, and I can say this about myself, having spent 30 years in acute settings, that we tend to think about all the things we do with the patient, but actually in carrying out rehabilitation, often it's the support from family members that's really key. And I think in this, we need to be looking at how we can engage that support from family members more in terms of the effect of rehabilitation packages. I know, and I confess myself that, we often think about the relatives as the people who can give us information or take the patient to clinics, but actually I think, seeing the supports that are around the patient to help with rehabilitation can be really useful. So I'll just quickly go through these. So the key elements that we identify as significant are, given the sort of role we've identified in terms of beliefs and idiosyncratic beliefs, the provision of information and normalizing symptoms is really key, and explaining the causes as well. So it's natural for people to be anxious and have catastrophic thoughts, in the absence of an underlying explanation of why these certain things are happening, why I'm feeling breathless, why I'm having, pain or fatigue. So normalizing explanations can be really helpful. Peer support is one of the, in terms of support recovery from any kind of critical illness, peer support, social support is such a key factor. So things that enable that peer support can be really helpful. And again, we'll plug organisations. I mean, there are other organisations, but ICUsteps is one that can facilitate that. But it also is a significant component of the programme. And again, as I say, involvement of relatives, both in terms of the fact of helping to identify and address sort of unhelpful beliefs and anxiety and panic on the part of relatives, but also enlisting and engaging relatives as active partners in, and friends and other people as active partners in rehab. the more psychological parts, the cognitive behavioural approaches, and these can be, we can draw on, as I was mentioning earlier, approaches that are used in cardiac rehab, pulmonary rehab, chronic fatigue syndrome management to look at identifying unhelpful beliefs about symptoms, ways of managing panic and anxiety, tackling unhelpful patterns of behavior, particularly in chronic fatigue, the pattern of boom and bust, overactivity, underactivity, which again in chronic pain is a very significant factor. Trying to identify that and help patients manage that and adopt a more graded approach to activity. And that approach to activity is sort of linked to managing catastrophic cognitions about, sort of interpretations of symptoms as a sign of something that's terrible is going to happen, can be really helpful. Increasingly in chronic disease management, we're using techniques from acceptance and commitment therapy, which I won't go into here, but they can be really helpful. Certainly in chronic pain, it's used quite widely. So they can be brought in to help with identifying realistic goals and helping patients to see this in the context of their overall beliefs and goals that they have in their life. And the last point we'll mention here is about compensating for cognitive problems. And really, it's important to identify those and help the patient and their relatives to understand them, and then to find ways around them, and using mobile phones and a whole range of things that we can take from cognitive rehab to help with that. There's and this isn't an alternative. That on top of that, there may be some people who will be appropriate well, there will be, not maybe any about it, there will be people who are appropriate to refer to psychological therapy services for particular discrete difficulties, anxiety, depression, post-traumatic stress disorder, and they will in England, improving access to psychological therapy services are widely available now. There may be specialist services as well. Also cognitive difficulties. There are community neuro rehabilitation teams quite widely around the country. Some people may be appropriate to refer to inpatient services, which are more variable around the place, but certainly it's worth looking for those. Older people may well be helped, or may be appropriate for older people's memory clinic services and also neuropsychology services. So it's important to flag those up and look for appropriate services if those are significant issues. I've cantered through that. Our last slide is on resources, and Dorothy mentioned the NICE guidance. I saw the thing about the slides. We will put them up, or we can put them up on the BPS website, but obviously they'll also, the presentation will also be available on the BPS YouTube channel, so the slides will be available there as well. The ICUsteps guide, ICUsteps.org, is where to go for that, and Dorothy mentioned the Intensive Care Society. Have I covered everything? I'm just conscious of time, Dorothy. Was there anything else you want to cover before we go on to discussion?
No, I think we've covered the main points, and it would just be really interesting to hear what other people have to say about it. Yeah. Let
me introduce our discussants. So Dr Debra Malpass is our BPS Director of Knowledge and Insights, going to be trying to help us address some of the questions in the time we've got available. Dr Michael Skene is a GP and A&E doctor from Exeter, and Peter Gibb is the CEO of the organisation ICUsteps that we've been mentioning. So we'll turn now, hopefully Mike and Peter will appear as if by magic, and we'll turn to your questions, and I've put a note to remind me to stop sharing the screen so you can see everyone. Ah, there, great. So hopefully Deborah's going to ask us some questions that we can, and there's Deborah as well. And we've got 10 minutes. Sorry that we've only got 10 minutes, but we'll do our best in 10 minutes to answer as many as we can.
So, good afternoon, everybody. So the most upvoted question is around PPE. So I don't know if you just want to briefly address that before we look at some of the more psychological questions. So psychologists are being asked to see COVID patients on the wards. What would your advice be on helping us approach this safely and managing ward staff?
Dorothy's probably best placed to answer that. Do you want to go ahead with that, Dorothy?
Yeah, I mean, I think, yeah, I've been seeing a lot of patients in critical care and other step-down wards, and we just follow exactly the same safety advice as all the other staff. So if we go into the critical care area, we'll be wearing full PPE, which I described earlier, and on other step-down wards will be a slightly lower level of PPE, just for surgical mask, aprons and gloves. But I think, you know, I think the PPE is exactly the same for a psychologist as it is for a nurse or anyone else. And I suppose my concerns were how are you going to really communicate with somebody in a very therapeutic way when you know, you look like some sort of alien monster. But I found that, yeah, with tone of voice, holding hands, just asking, the fact that you're asking them a lot of interested questions about themselves. And I've found if you speak clearly, we can understand each other. I think it's a sort of initial barrier, but you can break down the barrier. And I think actually it's really because it's been such a busy time for the clinicians, you know, just really rushing around from patient to patient. It's still really good to have somebody who can go and just spend some time saying, how are you feeling in all this, and how are you, just trying to, and also giving them information that they haven't been able to.
That's great. Thanks.
Grasp.
Thanks, Dorothy. And of course, psychologists use PPE in acute settings before this happened. I just mentioned the BPS guidance. We've got another work stream on adaptations to psychological services, which is tapping into the various adaptations that need to be made, including the use of PPE. So do look out for that guidance. But let's push on, because we've got a lot of questions to get through. What's next, Deborah?
So the next question is from Rebecca Horton. Does sense making with patients soon after discharge from ICU admission help mitigate PTSD?
I think that's a specific question, but also I think it might be worth bringing in Peter here to talk about this issue of picking people up after discharge. I mean, I think the answer, the short answer is yes, and I think Dorothy's mentioned you know, the importance of going over memories, trying to consolidate memories and process memories that for the various reasons we've talked about have not been processed. But I wonder, Peter, if I bring you here, one of the things that I was shocked, I have to say, I haven't worked much in ICU, but was surprised that people aren't often picked up very quickly on a routine basis after ICU. I know in some places like Dorothy's service they're picked up, but you know, I wonder if you could just address that point about the benefits of sort of proactive follow-up after people leave ICU.
I'd just like to say, I think the things that Dorothy covered were absolutely spot on, and they apply to general ICU patients as well as coronavirus sufferers as well. I was lucky enough to be in one of the 30% of UK hospitals with an ICU follow-up clinic. But the thing is, when you're on ICU, you're going to be very likely sedated. You may have very little or no recollection of actually being in the ICU at all. So the first thing that happens is you start becoming aware of where you are when you're in the general ward. And by that time, certainly under normal circumstances, you're isolated from any other intensive care patients. So you're battling with all these psychological issues and extreme physical weakness. And you think, this must just be me. If this was normal, it would be national news. And of course, being with psychological issues, particularly around the majority of patients who have delirium, whether it's hyperactive or hypoactive, you're kind of a little bit reticent to tell anyone about this because you think you're going to be locked up. I know I certainly did. And then if there's information, it helps a great deal because you can see it written down in black and white that these things are normal for someone that's in your condition, and it's like all the problems you have are like the skin of an onion, and each one that you can recognize and see, you can peel away a layer, and although you'll be left with a core in the middle that is specific to your situation in your case, it's a lot less difficult to deal with because it's that much smaller. So the information helps a lot. Even just being able to meet other ICU survivors can help, even without a formal drop-in or a peer support group. Just meeting other people who've been through similar issues, who can reassure you that they've been through it as well, can strip away those layers. And it doesn't take much, you know, a little bit of help with the back door, just getting people together for, say, physio rehab does so much good that it helps us get to a point, not where necessarily we understand everything that's been through, but we've addressed enough of it to actually be able to put it behind us and start returning towards a normal life, which is really the goal that we're trying to get to, rather than just survival.
That's really helpful. Thank you, Peter. That's really, really helpful. I think we go to the next question that Debra's going to pop it. The next question, I think, is, are patients being followed up in the community by psychologists? I think actually, maybe ironically, I'll go to Mike for that question, because it might be, I think us as psychologists might have a different view to the actual reality in primary care. So I wonder, Mike, if you want to just say a little bit about how GPs might manage people coming out of hospital, and how, you know, the sorts of services that might be around. Sorry, I don't want to put you on the spot. Don't.
No, that's fine. Yeah, of course. So I think, I guess first to start, so I work down in the southwest of the UK, which has been relatively spared so far of the pandemic. And so our numbers of patients leaving critical care compared to, say, London is much lower. And in terms of the experiences of the follow-up that patients receive post-critical care generally, as well as I think Peter points out, and it's been pointed out throughout this, is that this isn't unique to COVID, but has been sort of highlighted by the pandemic, that there is variability across the country in terms of what services are available and the follow-up that patients receive. And certainly also variable awareness of primary care physicians and GPs as to some of the challenges that patients face. And I think in the guidance, the point that the healthcare professionals need to have a good understanding of the patient journey to be able to support them, that critical care is certainly an area that quite a lot of GPs won't have much experience of working in, or the processes that might occur in critical care. And I think Steve Holmes in the questions sort of asked about sort of what the realistic expectations in terms of follow-up in the patient's experience of regaining symptoms. So patients sort of been asked to, you know, asking GPs at 10 days, should I be feeling back to normal and things like that. And I think sort of that awareness of GPs to know what's normal, to be able to reassure and guide and signpost patients is really essential for us to effectively support patients. I think we're used to supporting relatives. I think we, in modern day practice, see the patient as part of a family unit or wider unit, and relatives are an important part of that person's experience and recovery. So I think we often look after the wider family as well, and have prior knowledge if we've got that relationship before. And certainly patients who've got sort of health problems previously, we may know that patient before and be able to pick up subtle sort of cognitive changes in a patient that's alone. So I think we are well placed to support patients. I think having an understanding and awareness of the challenges that might be faced by patients following critical care, but also having an understanding of what services locally that we can access, because having that knowledge is only useful to the point where you know where you can direct patients. So I think that the communication from secondary care to ourselves, and for us to be able to communicate and advocate on behalf of patients and relatives, is the key, really.
Thanks, Mike. That's fantastic. Is there anything else you wanted to add to that, Dorothy?
No, I think
that's great.
Yeah, from Mike and Pete.
Okay, I'll maybe just try and squeeze in one more question, but there's a question about traumatized staff, and that clearly is an issue, but it's an issue I'm not going to address, because we've got a whole separate webinar on the issue of psychological needs of staff. So what I'd suggest is that you go and access that webinar through the BPS YouTube channel. Okay, have we got time to squeeze one more? I think that is it. I mean, this question is about, well, there's a few tied now, aren't there? But struggling to get patients seen on an ICU step-down ward because of limited psychology resources. I don't know who wants to tackle that one. I mean, what I would say is, and I think we emphasise this in the guidance, is that psychological care doesn't just come from psychologists, and there's a lot of psychological care that can be done without psychologists being there. I mean, psychologists are great, and as president of the BPS, I should, not be, but psychologists, are not the only people that can provide psychological care, and the reality is that in different places there may well be limits, and it may well be that psychologists are going to be available down the line, but actually in the acute setting there are the simple things that you've mentioned, Dorothy, that can be done.
Yeah, I mean, I don't know about Peter, did you find that there were some members of staff who were able to really support you after leaving intensive care? Nurses or?
It is very variable. I think one of the big issues is almost more the opposite of that. It's not the ones that support you so much as the ones who don't understand any of the consequences that ICU survivors will be dealing with, and might come in and throw a towel on the bed and say, go and wash yourself when you've not been up for 3 weeks. So it's just listening. If they can just be aware of the sort of things that we might have, so they can signpost us or signpost other professionals towards us, and try and spot those things. I think, as David was saying, it's not necessarily needing full psychologist qualifications all the time. It's just that awareness of these things that might be issues for the patients, and trying to nip them in the bud as soon as they can. Again, related to that, but also kind of one of the other questions, I know that for follow-up, when you're running a service, you have to schedule in certain times so that you make sure everyone gets the opportunity to be seen. But of course, patients will be ready to talk about this and deal with this at different times. Some will be wanted to talk about it as soon as they're on the general ward. Some will probably will try and deal with it on their own and get to a point where they can't and then need support. So the difficulties when you're running a service is to try and make it available for people when they're ready for it as well.
Okay.
And maybe more education and training for everyone about the patient experience of critical care.
Absolutely.
Like for GPs as well in some cases.
Oh, okay, well, I think we probably should draw it to a close there, because we are just over time. So I just want to say thank you to Dorothy for participating, and for Mike and for Peter for your, even though we unfortunately we didn't give you much time, but I think your contributions were really valuable, even though they were compressed. And thank you to all the people who've attended from wherever you. I do hope that you found it helpful. The resources are on the BPS website. We'll keep your questions, and I think we'll try and find some way of providing a follow-up to address some of those questions, and we'll let you know about that. So just thank you for your attending, and I hope you found it helpful, and I hope that you'll find the other BPS resources helpful. So thank you.